welcome to our 39th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. This platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Yenot Adela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's a pleasure to have Dr. Sushant Srivastava here with us to give a presentation on the aortic root replacement surgeries. Dr. Srivastava is an accomplished cardiovascular surgeon with extensive experience in aortic root replacement surgeries. He has successfully performed numerous surgeries and has a vast knowledge in the latest advancements in the field. We are confident that this presentation will be insightful and informative to our audience. To give you a background on Dr. Srivastava, he is a chief cardiac surgeon at Batra Hospital and Medical Research Center, New Delhi, a senior consultant cardiac surgeon at Devki Devi Max Heart and Vascular Institute. He is also an assistant professor of cardiothoracic and vascular surgery at the Faculty of All India Institute of Medical Sciences. Dr. Sushant assisted the first and subsequent 10 heart transplant of India at All India Institute of Medical Sciences, New Delhi. Dr. Sushant was in charge of donor management at the same faculty in New Delhi. He received training in ventricular assist device artificial heart at Temple University, Philadelphia, United States. He performed approximately 3,000 cardiac procedures at the faculty and now has a total experience of more than 11,000 cases. He is a versatile surgeon and operates coronary artery bypass grafting, valve repairs and replacements, and complex congenital heart disease with equal ease. This is just a glimpse of his 25 plus years of experience. So to give you a background on today's session, the session will last for about 90 minutes. And after that, we will have a few minutes for Q&A. So participants, please direct your question in the Q&A section and not the chat box. First, we are proud to present that we have started a partnership with HBG Medical Assistance, which is the best medical treatment in India. So to give you a little information about this, I welcome Dr. Adik to the stage.
If any of your patient is covered by insurance, then we do have a credit arrangement and we can treat this patient as cashless. For those doctors who use our services, who work with us very, very closely, for those cases which you want to manage locally, but you need a second opinion, you need an advice from your Indian counterpart, they get in touch with us, they share the medical reports, etc. with us, and then we put them in touch with our local doctors where they can discuss the case and then continue to treat the patient locally. We offer a lot of training and workshops in India. We do a lot of CMEs on ground also and webinars as we are doing it right now. We take it onto ourselves to do a lot of capacity building. And when I say capacity building, in last few years, we have helped doctors build 3 hospitals across the globe. The first hospital that we built was along with Dr. Wole Kukoi in Nigeria. And today, Ace Medicare Clinic, which is in a place called Ota, stands at 140 beds and very, very closely co-manage with our services there. The second hospital that we built was in Uzbekistan. It's a cardiac hospital. It was done in association with Zarmat Diagnostic of Uzbekistan. And the third one that we are building currently is in Kyrgyzstan, which is a diagnostic capability where we are going to do a very advanced diagnostic pathology, etc., etc. So we are deeply into capacity development also. And without taking much time, this is where we end. I'll keep the detailed presentation for a later day. I hopefully will meet you someday locally in Ethiopia. Along with Blue Health, we are trying to bring these workshops, CMEs on ground to you. And this webinar is just a beginning. And when I say it's a beginning, I must thank Dr. Sushant Srivastava. While the host was presenting, one thing that he mentioned, he could not mention was that currently Dr. Sushant is the chairperson of cardiac surgery at Artemis Hospitals in Gurugram. Artemis Hospital is one of the leading international hospitals in India. It's accredited not only by JCI, it's an NABH hospital. It's a JCI and NABH hospital. So it has got dual accreditation. And very, very proudly, Dr. Sushant Srivastava is leading the cardiac surgery department of Artemis Hospital. I have known Dr. Sushant for almost 9 years now. And all I can say about Dr. Sushant is if something is going to happen to me or any of my family member which needs a cardiac intervention, blindfolded, we are going to go to Dr. Sushant. That is the kind of trust we have on him. It's a proud moment for me to present him to you. And with that, all over to you, Dr. Sushant. Thank you so much.
Thank you, Abhi, for that very generous introduction. I'm happy, I'm pleased to be here with all of you and for the opportunity that you've given me to talk to you. The topic of today's discussion is aortic root replacement, indications and techniques. Now, I'd like to think of it more as a conversation than as a formal presentation. I hope to present to you why aortic root replacement is done, how it is done, and what to expect as outcomes from this surgical procedure. So let's begin. Aortic root replacement is done for a variety of conditions, and these conditions are together known as aortic root pathology. And very briefly, aortic root pathology includes aortic stenosis or aortic regurgitation. It's either the aortic valve is narrowed or it becomes regurgitant or begins to leak significantly, for aortic root aneurysms and aortic dissection. So basically, there are three conditions for which aortic root replacement is done. The three are together clubbed under the heading of aortic root pathology. The first one is a problem with the aortic valve, either a stenosis or an insufficiency. The second is a problem with the size of the aorta. It's called aortic root aneurysms. The aorta balloons out, often to a huge size. These are known as aortic aneurysms. And finally, the aortic wall can split into two, and that condition is known as aortic dissection. So the problem with aortic root pathology is it hasn't received enough attention. While all of us are familiar with coronary artery disease and heart valve disease, many of us are not very familiar or do not in our day-to-day practice come across or see aortic root pathology. The other problem is aneurysms can often be absolutely silent or asymptomatic. So a patient can have an aneurysm growing inside his chest and be completely unaware of it. And sometimes these aneurysms will present with a life-threatening complication. Dissections, on the other hand, present dramatically. And as we shall see, dissection, when they do present acute dissection, they can be confused with other conditions and valuable time can be lost, excuse me. And the final problem with aortic root pathology is surgical treatment is not commonly available. It's not available in district hospitals or even in state hospitals. So surgical treatment of good quality can only be undertaken in tertiary care centers. What is the incidence of aortic aneurysm? Since it is an uncommon problem, the incidence is not as high as other cardiac or heart disease. So the incidence of thoracic aortic aneurysms is estimated to be 6 cases per 100,000. An aortic dissection is even less common. The incidence is 3 cases per 100,000. Now, before we begin to look at aortic root pathology, let's look at the normal aorta. And here I have a picture of the normal aorta as it looks at surgery for you. This is what the normal aorta looks like. So the normal aorta is a tubular structure and emerges from the heart and blends with the arch of the aorta at the origin of the innominate artery. And there you can see that there is no dilatation or outpouchings in this aorta. Now, what constitutes the aortic root? If we are to talk about aortic root replacement, we must first define the aortic root. So these are the parts of the normal aorta. The aorta begins at the junction with the left ventricle, and that junction is known as the aortic annulus. Then it dilates into a short segment which gives rise to the two coronary arteries around the aortic valve, and this dilated portion is known as the aortic root or the sinuses of Valsalva. This is the outpouchings or the dilatations are known as the sinuses of Valsalva. Now, this dilated part of the aorta blends with the ascending aorta or the tubular ascending aorta, and that junction where it meets the ascending thoracic aorta is known as the sinotubular junction. The aortic annulus, the sinuses of Valsalva, and the sinotubular junction together constitute the aortic root. Now, often disease of the aortic root involves the ascending thoracic aorta as well. So when we treat for aortic root pathology, we often have to include the ascending thoracic aorta into the surgical strategy. Now, the ascending thoracic aorta terminates at the arch. It ends where the aortic arch begins, and the arch is said to begin when the first artery comes off, when the first major artery comes off the ascending aorta. And this artery is the innominate artery. It divides into the right subclavian and the right common carotid artery. The common carotid artery, as you know, goes into the brain. The subclavian artery goes into the right arm. So at the origin of the innominate artery, the ascending thoracic aorta becomes the arch of the aorta, and it gives rise to three major branches: the innominate artery, the left common carotid, and the left subclavian artery. And then it turns down and continues as the descending thoracic aorta. Now, the aorta is not just a tube, it is a live structure. And the aorta has a measure of strength which helps it perform its normal function. So the aorta is elastic. When the left ventricle ejects blood into the aorta, it expands, and then it contracts and pushes the blood onward. So most of the elasticity and tensile strength of the aorta is derived from its adventitial and medial layers. The aorta has three layers: the adventitia, the media, and the inferior. Most of its strength resides in the adventitial and medial layer. The smooth muscle cells of the medial layer is muscle. The smooth muscle cells synthesize and degrade elastin, collagen, and proteoglycans. So it is a biologically or metabolically active structure. Now, when things go wrong with the aorta, when the aorta becomes exposed to aneurysms, in many cases, this is what we see under the microscope. It is called cystic medial degeneration. In cystic medial degeneration, there is a dramatic loss of elastic fibers and smooth muscle cells with the accumulation of a basophilic amorphous material. So the normal structure, the normal microscopic structure of the aorta is replaced with the accumulation of a basophilic amorphous material. And with that, the strength of the aorta declines. When that happens, a localized dilatation of the aorta can occur, and an aneurysm occurs. And since we are talking about ascending aortic aneurysms or root aneurysms, this dilatation of today's discussion is in the aortic root or the ascending aorta. In general, aneurysms occur in that way. An aneurysm is a localized dilatation of a blood vessel or a cardiac chamber caused by a congenital or acquired weakness of the wall. And cystic medial necrosis causes weakness in the wall of the aorta. Now, this is what an aneurysm looks like. If the chest is open, the aneurysm is often so large that it is seen to occupy most of the inside of the chest, most of the inside. It pushes the heart away, and in this video, you can see that all that is visible at first sight is the aneurysm. The heart has been pushed away to the left and is barely visible on opening the chest and the pericardium. So the other serious complication of an aneurysm is leakage. An aneurysm can leak and cause severe complications, severe hypotension, and threaten life. Can you see this picture?
Yeah.
We can see the leaking aneurysm picture, sir.
You can see the clots and the leaking aneurysm. Okay. So we'll have to make do with the pictures, because I think internet, somewhere there's an internet problem and the videos can't be transmitted. Can you see this?
Yes, sir, we can see the picture.
Yeah, okay. So the other condition is dissection of aorta, and dissection of aorta is happens when blood is forced in between the layers of the aorta, and it splits the wall of the aorta. You can see that the wall of the aorta is split into two. The true lumen is where the blood used to flow before the dissection happened. The false lumen is within the wall of the aorta, and often blood flows in both lumens. And sometimes the false lumen is larger than the true lumen. And on the right side, you can see the split layers of the aorta from the inside. Now, sometimes the false lumen is so large that it compresses the true lumen. The other important consequence of dissection is some vital arteries, some arteries to vital organs can arise, can be split, their origins can be split, and they now, after the dissection, arise from the false lumen, and the blood flow to these vital organs can be seriously compromised. Now, when we say that the incidence of dissection is 3 per 100,000 population, are we referring to correct numbers? In one study, it was revealed that the ante-mortem diagnosis of dissection was made only in 15% of patients. So the numbers that are stated in the literature may only be the tip of the iceberg. And as diagnostic facilities and awareness increase, as healthcare facilities penetrate to smaller cities and towns and even to rural areas, the incidence appears to be increasing. This is because there's routine screening, there's improved imaging, and increased clinical awareness. Now, what is the etiology of aortic aneurysms? What is the cause of aortic aneurysms? A definite cause for aortic aneurysms is not known. Is it a metabolic disorder? That's possible because there's cystic medial necrosis in the wall of the aneurysmal aorta, and that does seem to be a metabolic problem. Aneurysms are associated with certain clinical conditions, and the most prominent of these clinical conditions is Marfan syndrome. Marfan syndrome is a connective tissue disorder. It is inherited as an autosomal dominant, and Marfan syndrome has a strong association with aortic aneurysms. There are other connective tissue disorders such as the Ehlers-Danlos syndrome. There are familial aneurysms. And a very important condition which is associated with an aneurysmal ascending aorta is bicuspid aortic valve disease. Many of you must be familiar with what a bicuspid aortic valve is. A bicuspid aortic valve is the most common congenital cardiac anomaly. In this condition, the aortic valve consists of only 2 leaflets instead of the normal 3. These at birth, most of the bicuspid valves are asymptomatic. And as the individual grows during adolescence or middle age, these valves either become stenotic or regurgitant. In some cases, these valves can remain asymptomatic to an advanced stage. Now, the importance of bicuspid aortic valve disease with respect to aortic aneurysms or ascending aortic aneurysms is that in bicuspid aortic valve disease, the aorta is more prone to dilate and become aneurysmal. So many of about 25 to 35% of patients with bicuspid aortic valve disease will at some point in time develop ascending aortic aneurysms. There can be aneurysms associated with infection, and these are known as mycotic aneurysms. And despite the name mycotic, these infections are most often bacterial and not fungal. And in older people at an advanced age, atherosclerosis also makes a contribution to ascending aortic aneurysms. Now, the diagnosis of ascending aortic aneurysms is difficult. The reason is most of them are asymptomatic. The aneurysm forms and expands inside the chest silently. So many of these aneurysms can be incidentally diagnosed on chest X-ray or for echo done for some other purpose, for some other illness, or in a routine health checkup. Sometimes the aneurysm becomes so large that it begins to press on the breastbone or the sternum, and then the patient complains of chronic pain. When he's investigated, the aneurysm is discovered. Now, the diagnosis of aortic dissection is very dramatic. In acute dissection, the patient presents with a severe, sudden onset, severe chest pain radiating to the back. Often there is history of hypertension. Hypertension is an important cause, uncontrolled hypertension is an important cause of aortic dissection. Now, as we discussed, the wall of the aorta splits into two, and now blood flows into two parallel channels, the true lumen and the false lumen. And some important arteries can now, post-dissection, arise false lumen. And therefore, a patient who presents with severe chest pain radiating to the back and also has an absent peripheral pulse is very likely to have acute aortic dissection. So when you get a patient with chest pain, sudden onset, severe chest pain radiating to the back, be sure to check all the peripheral pulses, including the carotids. And if there's an absent pulse, that should arouse a strong suspicion of acute aortic dissection. Sometimes the dissection can extend backwards towards the aortic root or the aortic annulus. And as we know, the two coronary arteries, the left coronary artery and the right coronary artery, arise from the aortic sinuses. If the sinuses are dissected, then blood flow to the myocardium or in the coronary arteries is compromised, and that can lead to a heart attack. So you can have a patient with acute aortic dissection who also has had a heart attack as a result of the dissection. These people are extremely sick and survival is pretty low. Sometimes this can happen with the spinal cord arteries, and there can be spinal cord ischemia and paraparesis or paraplegia. Rarely, the false lumen expands to such an extent that it presses on the superior vena cava or causes airway compression, or it can cause hoarseness of voice or Horner's syndrome. Some patients will present. The involvement of the carotids is about 40% in dissection of the ascending aorta, yet stroke is quite rare. Most of these patients do not have stroke at presentation, but 10 to 12% patients will present with a fainting attack or syncope. Sometimes the dissection can leak inside the pericardium, and I have a case which leaked inside the pericardium to show you in the coming slides. This can cause compression of the heart and cardiac tamponade, and also acute circulatory failure or stroke. If the leakage is in the pleura, it is much larger because the pleural cavity is much bigger, and these patients can be severely depleted of circulating blood and be in very severe hypotension. And sometimes the dissection will just rupture and cause sudden death before the patient reaches hospital. So there are two systems of classification in vogue for for aortic dissection. The first and by far the most popular classification system is known as the Stanford classification. It divides dissection of aorta into two types. If the tear is in the ascending aorta, then it's known as Stanford A. And sometimes the dissection, even though the tear is in the ascending aorta, the dissection will extend all along its length to a variable extent. But if the dissection, or if the tear is in the descending aorta and the ascending aorta is spared, then it is known as Stanford type B. So this system has two types, classifies acute aortic dissection or aortic dissection into two types. If the tear is in the ascending aorta, it's Stanford A. If the tear is in the descending aorta, it's Stanford B. The other older system of classification was proposed by Michael DeBakey, who was a pioneer in aneurysm and dissection surgery. Type 1, the tear is in the ascending aorta, and it extends all along the length of the aorta, throughout the length of the aorta. Type 2 is when the tear is in ascending aorta, but the dissection is limited to the ascending aorta. Type 3A is when the tear is in the descending thoracic aorta, in the descending aorta, and the dissection is limited to the thoracic aorta. And type 3B is, again, the tear is in the descending aorta, but the dissection extends into the abdominal aorta. For all practical purposes, the Stanford classification is the one in use nowadays. So there's also a classification based on the time frame. If dissection presents within 2 weeks from the onset of chest pain or from presentation, the patient presents within 2 weeks, it is called acute dissection. If the patient presents between 2 weeks and 2 months, it's called subacute dissection. And if it is more than 2 months old, it's called a chronic dissection. And all these three categories behave differently. So how do we establish the diagnosis of an aortic aneurysm or aortic dissection? We need to do either an aortography. An aortography used to be done when the CT angio was not available, and there used to be an injection of contrast in the aorta, and it used to reveal either the aneurysm or the dissection, but it was fraught with danger because these aneurysms can rupture, the dissection can extend or become complicated with aortography. So aortography has more or less been abandoned as a diagnostic method. The gold standard nowadays is contrast-enhanced computed tomography, or the CT angio. An MR angio can also be done, and it produces more precise pictures. But in an emergency situation, the CT angio is to be preferred because the MR angiography takes much longer to do. So this is what a CT angiogram of the ascending aortic aneurysm looks like. You can see that the aortic root is dilated, and much or the whole of the ascending aorta is dilated. And this aneurysm is pretty large, possibly 7 or 8 centimeter across at the point of maximum dilatation. So this is the kind of information the CT angio provides. And based on the CT angio, surgery can be planned. So what does the CT angio tell us? It establishes the diagnosis. It defines the anatomy precisely. It tells us the size, the extent, the origin of the coronaries, the origin of the arch vessels. However, it does not pick up whether the aortic valve is competent or not, or whether it is stenosed or not. So the CT angio needs to be supplemented quickly with echocardiography, and if transthoracic echocardiography does not produce good images, then transesophageal echocardiography needs to be done. So what are the indications for surgery? Now, the indications for surgery for aortic aneurysms and dissection are different. Aortic and the most serious complication of an aortic aneurysm is rupture or leakage. And studies have revealed that rupture or dissection is likely to occur at a median size of 5.9 centimeter in the ascending aorta. So to preempt that complication, surgical therapy is advised when the aneurysm reaches a size of 5.5 centimeter. That briefly is the criterion on which aortic aneurysm surgery is based. However, I must clarify that if the valve is bicuspid and requires surgery of its own, then 4.5 centimeter is taken as the upper limit of aortic dilatation. So if you have a bicuspid aortic valve which is stenotic or regurgitant and requires surgery, and the ascending aorta is 4.5 centimeter in diameter, this patient should not just have valve surgery, he should have valve replacement and aortic root replacement, which means a composite replacement of the ascending aorta and the aortic valve. For all other aneurysms, for all other ascending aortic aneurysms, the limit is 5.5 centimeter. Now, acute aortic dissection is an emergency, and most often they are taken up for surgery under emergent circumstances. And I've already mentioned that the bicuspid aortic valve requiring valve replacement should have aortic root replacement if the maximum diameter is 4.5 centimeter. So the classical operation for aortic root aneurysms is replacement of the ascending aorta with a composite graft. A composite graft is a tube graft, a synthetic tube graft with a valve at one end. The valve is for replacement of the aortic valve, and the tube is for replacement of the aortic root and the ascending aorta. And this operation, this ingenious operation, was described by Bental and De Bono in 1968. It has been modified quite a bit, but these were the proposals. These Bental and De Bono proposed and did that operation for the first time in 1968. So the operation has to be done on cardiopulmonary bypass on the heart-lung machine. This is the usual scheme of cannulation for connecting a patient to the heart-lung machine. The ascending, for all open heart surgery, the arterial inflow cannula or the aortic cannula goes into the highest part of the ascending aorta or into the proximal arch. Venous blood is drained from the superior and the inferior vena cava. It goes through an oxygenator, it is oxygenated and returned to the patient through the arterial cannula in the ascending aorta, in the arch of the aorta. Now, with the circulation having been taken up by the heart-lung machine, the aorta can be clamped and the operation can be done in a bloodless field. So the heart, if a clamp is placed between the arterial inflow cannula and the heart, there's very little blood returning to the heart. So the operation can be done in a field with clear visibility. So sometimes the aneurysm will involve the proximal arch, or it will involve the quite a bit of the arch, or even go beyond the arch. Or in dissection, the innominate artery can arise from the false lumen, and if we cannulate at that point, then the arterial inflow cannula will go into the false lumen and make things worse. So we have to adopt special modifications for surgery sometimes, and we have alternative modes of cannulation. This is when the ascending aorta is dilated or aneurysmal, the cannula can be placed high up in the arch of the aorta, and the clamp can be placed between the arch and the aneurysm. Okay, so sometimes we cannulate the subclavian artery, and the subclavian artery can perfuse retrograde into the aorta. It can also be clamped to provide antegrade perfusion or perfusion to the brain when the circulation is stopped, and we'll come to that in a bit. So this is another alternative cannulation strategy. In this patient, the aneurysm extended well into the arch. In fact, it was a chronic dissection. So we anastomosed a tube graft to the innominate artery and introduced the arterial inflow cannula at the other end of this graft. Now, the first step is resection of the aneurysm, and I'm sorry you can't see this. Can you see this?
Yes, doctor, it's visible.
Can you see the picture? Yeah. So I have a picture and a video both for you. So if you can't see the video, you can see the picture. So the first step after placing the patient on cardiopulmonary bypass, we need to clamp the aorta and separate it from the circulation. And then we open the aneurysm. I wish you could see the video. These aneurysms are often so large and the wall is paper thin that when we open them, we realize that rupture was imminent and that it is just a matter of luck that the patient reached hospital. So the first step is to resect the aneurysm and then replace the aneurysm with a composite graft. And there are many kinds of composite grafts. The classical graft has a metallic valve or a mechanical prosthesis at the end of a tube. So nowadays, we also have tissue valves for elderly patients who cannot take blood thinners on a regular basis. So for these patients, we have a conduit or a tube graft with a tissue valve, which does not require as much anticoagulation as a mechanical prosthesis. Now, the Bentall operation is, once the aneurysm has been resected, once the aneurysm has been resected, it has to be replaced with a composite graft, and this is a composite graft, and you can see those threads passing through the annulus of the prosthetic valve. This is the first step of the operation. Now, once the graft has been positioned, we need to cut out the coronaries from the diseased aorta and re-implant them into the graft. So these coronaries are cut out with a rim of aortic tissue, and they're referred to as the coronary buttons. There are two coronary arteries, the right and the left. I think you can see the orifices of both coronary arteries in this picture. And I wish you could see the videos. Cutting out the coronary buttons is a technically demanding job, because while you have to cut out the buttons, you have to be very careful not to hit the coronary behind it. So this is how we do it. So the coronary buttons have to be cut out at that point where you can see the forceps, the tip of the forceps touching the graft, and windows are cut out on both sides of the graft, and the left and the right coronary buttons are re-implanted there. Now, sometimes the aneurysm extends into the arch, and we need a special technique to go into the arch, because if we open the arch, air will fill the arteries of the brain or the carotid arteries, and the patient will have a stroke. So we need to stop the circulation, and this method is known as total circulatory arrest. And the steps are to cool the patient to 15 degrees centigrade or 18 degrees centigrade. At 18 degrees centigrade, the metabolic requirement of the brain and other vital tissues is significantly reduced, and therefore if there's no circulation, these organs can manage undamaged for a period of time. Then the heart-lung machine is stopped for up to 40 minutes. For up to 40 minutes, there's a good possibility that the brain will not sustain damage at that temperature, even though there is no circulation. And we've added to this something known as antegrade cerebral perfusion. We cannulate the arteries, both the carotid arteries, or we have a graft in the innominate artery or one or the other carotid artery, and we circulate a small amount of blood, about 600 ml per minute, through these arteries to provide additional protection to the brain. So this is antegrade cerebral perfusion to the subclavian artery. This is antegrade cerebral perfusion through the right subclavian artery. The cannula is in the right subclavian artery, and there's a clamp that prevents blood from going towards the arch, and the circulation is antegrade towards the brain. So this is the completed operation. This is the completed operation. The aneurysm has been replaced with a graft, and the coronaries have been reimplanted, and this is under total circulatory arrest. There's no aortic clamp. The distal end or the far end.
Doctor, the photo is not visible actually. It's blank.
The video? No?
No, we can only see the title, that's it. The photo is not visible, neither the video.
Okay, we'll show you some other pictures later on in the session. This is something I have no control over. So we stop the circulation and go into the arch, and there's no circulation for about 40 minutes, and we do that anastomosis. So this is the completed operation. The aneurysm is gone, and you can see a tube emerging from the heart and connecting to the arch of the aorta. The coronaries are in the proximal most part of this tube. They've been reimplanted into the graft, and the patient has a new circulation. And since he does not have any weak parts in the aorta, the aneurysm is gone. He is safe from the complications of leakage and rupture. So, so we've studied our post-op cases, and you can see the contrast between the pre-op CT picture and the post-op CT picture. Can you see this picture?
Yes, sir.
Yes, doctor.
Yeah. So we have in the pre-op picture on the left side, you have a large aneurysm, a very large aneurysm threatening to rupture. On the right side is the post-surgical picture, and you have a tube graft, and you can see the prosthetic valve at the end of it. You can see a little of the left coronary artery emerging from the graft. That thread-like thing coming out of the bottom of the graft is the left coronary artery, which has been reimplanted. And you can see that the graft merges imperceptibly, almost imperceptibly, into the arch of the aorta. So that's the basic operation for aortic root aneurysm. Now, aortic dissection is a different ball game. You can see the dissected aorta from the inside here. The aorta is split into layers, and the false lumen is full of organized or chronic clot or thrombus. So this is a much more messy affair. The basic operation for Stanford A dissection in many cases remains the same. We do an aortic root replacement. And what does aortic root replacement achieve in these patients? The aortic root replacement removes the tear in the aorta, or the point of entry of blood into the aortic wall. And once that tear or the entry point has been removed and the aorta has been replaced with a strong graft, then the false lumen does not have a circulation, and it slowly clots and shrinks over the next several months or years. So the risk of rupture is removed, and the false lumen does not expand in many cases. In some cases it does, and then it requires additional treatment. And this is because there's another tear somewhere down the line. So this is what an aortic dissection looks like from inside. I have some interesting cases of aortic dissection, and this is a case of chronic dissection, which I want to share with you. This was a 64-year-old man. He had had CABG or bypass surgery at another institution 7 years ago. He presented with increasing breathlessness on exertion. Now, when we did his echo, we found that there was a flap in the aorta and dissection was suspected. And he was subjected to a CT angio, and he was discovered to have chronic dissection of aorta. At some point in time, he had acute dissection. He must have had chest pain, but that it remained undiagnosed, and he was lucky to survive and presented more than 2 months later to us. And at that point, he was defined as diagnosed as having chronic dissection of aorta. And the dissection had extended into the aortic valve, and he had severe leakage of the aortic valve or severe aortic regurgitation. However, this patient did not have angina. He had coronary artery disease for which CABG had been done, but he did not have angina. It told us two things. One, the coronary ostia were probably not involved, and even if they were involved, the grafts were flowing well. So he was lucky to survive, and he was lucky to have no angina. So we did a detailed echo, and as I said, he had severe aortic regurgitation. Luckily, his left ventricular function was normal. We did a CT coronary angio, and the CT coronary angio showed 3 patent vein grafts from the previous bypass surgery. The native coronary arteries were not well seen. Now, a conventional coronary angio would have given us more information, but because of the dissection, the cardiologist refused to do a conventional coronary angio. And this is what the CT angio looked like. You can see that severe outpouching on one side of the aorta. That's the chronic dissection, the chronic dissecting aneurysm. You see these 3 tube-like structures emerging from the ascending aorta, and they are the grafts of the previous bypass surgery he had had. So we took him for surgery, and we intended to repair the dissection. And since the grafts were patent, we had planned to reimplant these grafts into the neo aorta or the prosthetic aorta. So we did a redo sternotomy. In a redo case, in a second-time operation, the heart is stuck to the chest wall and to the pericardium, and very careful dissection has to be undertaken so that no vital structures, no grafts, no arteries, no chambers of the heart are damaged, because there can be profuse bleeding and even death if that occurs. So we took him up, we did a redo sternotomy, but there were several surprises in store. The CT angio had told us that there were 3 grafts, and the 3 grafts were, all 3 of them were patent. The patient did not have an operation record because this was done 7 years ago. So at operation, we discovered that he had a 4th graft. Now, this graft was not seen in the CT angio because it was blocked. So now we had a problem on our hands. We needed to do something about that blocked graft, because while the other 3 grafts are flowing, this was not flowing, and obviously the patient needed that graft. So we needed to redo that graft. Surprise number 2, there was another surprise. One of the grafts was placed high up on the ascending aorta, and there wasn't enough space to place the clamp. So we decided to sacrifice this graft and do it and find some other solution to it. So the revised surgical strategy was we harvested 2 grafts in a button. Of the 3 grafts that were patent, we cut out 2 grafts with a piece of the aortic valve. And we divided the top end of the high graft which was interfering with the aortic clamp and the distal anastomosis. If we had retained that graft, it would probably have been caught in the distal suture line. When we stitched at the top end, that graft would have become blocked. So we divided the top end and left it free in the pericardium. And the third thing we needed to do was to do a graft to the right coronary artery, the one which was blocked and not seen on the CT angio. So this is, we cut out this button and you can see those two holes inside that button. Those are the two patent grafts. So we cut this out with a piece of the aneurysmal aorta and we reimplanted it on the neo aorta or the prosthetic graft. And there you can see the aorta has been changed, the aneurysm is gone, and that messy thing on top of the graft is the button with the two patent grafts. Now, the third graft is what you see held in the forceps, and that we lengthened that graft with a piece of vein and reimplanted it onto the neo aorta. And finally, we did a graft for the right coronary artery. So this was a very interesting case, and though we did a lot.
Hello, doctor.
There's one more case. That's the graft on the prosthetic aorta. There's one more case that I'd like to show you. That's the completed surgery. The button, the lengthened graft, and the new graft to the right coronary artery. Now, we've encountered ruptured aortic aneurysms. I just want you to see what a ruptured aortic aneurysm looks like and how how life-threatening and how critical it is. This was a 57-year-old man who presented with chest pain and hypotension. Echo showed a large pericardial effusion. A ruptured aneurysm was suspected and a CT angio was done. And when we opened the chest, you can see that blue bulging through the pericardium. The pericardium has not yet been opened, and you can see the blood inside the pericardium, pushing it and threatening to come out. And when we opened the pericardium, we brought out a lot of clots. And you can see that little hole in the ascending aorta from where the leak had occurred. Now, this is another interesting case. This is a patient, an overseas patient, a 20-year-old boy. He had coarctation of aorta. For some reason, it wasn't diagnosed in his country in infancy. And as a result of the coarctation, he had very high blood pressure. The blood pressure led to a Stanford A dissection, and both subclavians were from the false lumen. So we needed to do the coarctation and the Stanford A dissection in one sitting through one incision. And a coarctation, as you know, is in the proximal part of the descending aorta, which is very hard to approach through a median stenotomy. But we planned this operation, and we went on bypass with two cannulae, one in the carotid and one in the femoral artery. And we cut out the coarctation and replaced the whole ascending aorta, the arch of aorta, and the proximal descending aorta, and connected all the head, neck, and upper limb arteries to prosthetic tubes. And this is what it looked like in the end. So we have a prosthetic aorta coming out from the heart, and we have those tubes connecting to the carotids and the subclavian. And you can't see the resected coarctation very clearly here in this view, but the coarctation has been resected, and the circulation to the lower limbs improved dramatically. And there's endovascular aortic repair too for aortic aneurysm, and this technique is making its headway into ascending aortic and arch aneurysms. Though in a limited way, it is useful for sick patients, but that's for another occasion. And we can discuss this when we have the time and when this is the topic. So thank you very much for a patient hearing. Thank you very much for giving me this opportunity to have this conversation with you. I'll be happy to answer any questions if you have them. And I'm sorry.
Thank you so much, Dr. Sushant. Adam, you may kindly coordinate for any questions.
So participants who have any question can write their questions in the Q&A section.
Doctor, am I allowed to ask a question?
Yes, of course.
Dr. Sushant?
Yeah.
Yeah.
Go ahead.
So many a times for where there is aortic regurgitation and aortic root is involved, the doctors prescribe a homograph. But then there are case selections where a Bental is preferred over a homograph. What kind of candidature would you prefer over a homograph for a Bental?
Look, a Bental is a standardized operation and it has withstood the test of time. A homograft is something is a piece of aorta with the aortic valve taken from a cadaver and preserved in a valve bank or a homograft bank in liquid nitrogen. The durability of the homograft is suspect, as is the availability. So homografts are not available everywhere. And sometimes these patients will need urgent surgery. And in waiting for a homograft, they can have a complication. A very famous person who had a homograph, who wanted a homograph, but ended up having a prosthetic graft, a biological valve, is Arnold Schwarzenegger. He had a bicuspid valve. He had an aortic root replacement in 1997 in the United States at that time. But that operation went wrong and they had to do a biobental with a biological valve. And he's had a second procedure a couple of years ago. So, the standard procedure is a bental. A homograft is not commonly available.
Thank you, sir.
Dr. Sushant,
Yes, sir.
there's a question in the Q&A section, if you can access.
I can't access it. Can you read it out to me, please?
Okay. Is there any place for medical management in aortic aneurysm and or dissection?
Yeah, I will tell you when. Medical management is preferred over surgical management when the aneurysm is not very large. So what we need to do, we need to control blood pressure and we need to give them beta blockers because it reduces the force of ejection from the heart and the aneurysm enlarges more slowly. And these patients should have a CT angio for precise measurement of the growth rate of the aneurysm every year. And if the growth rate is less than 2 millimeter, then they can be managed medically. Once they reach the threshold of surgical management, then they can be switched to surgery. In chronic dissection, if the aneurysm is not large, management consists of controlling hypertension. And these often for many years, these aneurysms don't large.
Yeah, I think this is it. Thank you so much, both Dr. Atik and Dr. Sushant. It was a really interesting session. I know we have a little technical difficulties when we start. We started a little.
Get used to it and overcome them.
Yeah, we will try to improve in the next sessions, hopefully, and we'll do that. Thank you so much. If you have any last remarks that you want to add, I'll give you the stage once more.
Dr. Binyam, I have a last remark to make.
Yes, please do. Please go ahead.
We would want to come and present physically. This webinar thing is a shortcut, and a face-to-face interaction matters a lot more. We are able to discuss better, we are able to present better.
Yes.
Maybe we should try and create a presentation on ground.
Yes, that we are more than willing to do that. And as our agreement, we can prepare that every once in 3 months, right? Or maybe even frequently, more frequent than that. We can discuss, and we are more than open to take this session in person.
Dr. Sushant, what's your comment on that?
Absolutely, absolutely.
Yes, thank you.
Sure.
All right. Thank you so much, guys.
Thank you very much. Thank you.
Thank you, Dr. Sushant. Thank you so much for your time. I know it's very late in the night. It's past 11 here, but we are
Thank
very, very grateful to you, sir.
Yes.
you.
Thank you, Blue Health team, for organizing this. We are very
Yeah.
grateful. Thank you, Dr. Kritika.
Thank you so much, guys. On behalf of Blue Health and both our participants, we would like to thank you all too.
Thank you.